Observe the patient in standing if possible or seating if not. Move around the patient to observe the following: the integrity of the skin for any open wounds, burns, open fractures or abrasions, any redness for signs of infection or inflammation. Look for a hematoma, especially in the deltoid area. This can often be caused by direct trauma to the superior part of the humerus, indicating a fracture. Look for signs of swelling, which is less obvious in the shoulder. Make sure you include the subacromial space for any indication of a possible subacromial bursitis. Look at the overall posture of the cervical spine, glenohumeral joint and scapular alignment. You are looking for deformity or any possible dislocations or subluxations of the acromioclavicular joint, sternoclavicular joint and glenohumeral joint, as well as any muscle spasm or protective behaviour. Observe the deltoid contour from the front, which will be lost by a possible anterior glenohumeral joint dislocation as the head of the humerus has inferiorly migrated. A proximal humeral fracture can also give a similar appearance. Then go on to look for any bony contour changes or any visible deformity along the length of the shoulder girdle and ribs. Assess the scapular position, but compare this to the other side, as winging scapula are common, but may indicate a long thoracic nerve palsy or neuritis if unilateral. With the muscles, observe them for wasting of the rotator cuff in the supraspinatus fossa and check the infraspinatus fossa posteriorly for an acute on chronic tear. Rupture of the long head of the biceps can be detected by a bunching of the muscle in the mid-humerus. Here we want to assess the bones, joints and soft tissues for tenderness and signs of disruption. Anteriorly, palpate along the length of the shoulder girdle. Start by palpating the sternoclavicular joint at the apex of the sternum where the clavicle articulates. Note any tenderness or prominence of the joint compared to the other side. Migrate laterally along the length of the clavicle. Just before the acromion, you can drop down onto the coracoid process of the scapula, then back up to the clavicle, and then to the acromioclavicular joint, where you will feel a ridge of bone. You can then drop off the edge of the acromion to palpate the head of the humerus, which is sitting under the acromion and the acromioclavicular joint. The dome of the head of the humerus can be felt along its borders. Just inferior to the distal end of the acromion in the dip, a subacromial bursa may be felt if it is inflamed. Then palpate further inferiorly around the head and superior part of the humerus and then down into the shaft. Palpate the bicipital groove on the anterior humerus, and to palpate the rotator cuff insertion, take the arm into extension and some internal rotation if possible to expose the greater and lesser tuberosities. Nerve and artery assessment. Note to see if there is any reduced sensation in the badge area of the lateral deltoid, which is suggestive of axillary nerve damage. Check the first dorsal web space of the thumb for radial nerve damage. For perfusion, check the radial pulse and capillary blood flow. This can be checked by applying pressure to the nail bed until it turns white, then releasing. The tissue should return to a pink colour within 2 seconds. Palpate along the spine of the scapula. This spine separates the supraspinatus and infraspinatus fossa. Then go on to palpate within the fossas for any possible bony or muscle tenderness, as this is the origin of supraspinatus and infraspinatus respectively. Teres minor is also located within the infraspinatus fossa and is assessed as one unit with infraspinatus. Palpate along the medial edge of the scapula, passing superiorly to inferiorly and then laterally along its border towards the axilla. Subscapularis can be difficult to palpate as its origin is on the anterior wall of the scapula. However, if you place your fingers into the posterior wall of the axilla, you can palpate the muscle if you ask the patient to medially rotate the arm or resist this movement. Observe the active range of movement of the cervical spine, the bilateral side flexion, rotation, flexion, extension, protraction and retraction. Monitor for reproduction of symptoms, asking the patient to report any pain or symptoms with each movement to assist in the differential diagnosis process. See 4 or 5 nerve root irritation can refer to the shoulder girdle. Ask the patient to flex and extend and then abduct the arm. Observe the scapula from behind and that it moves smoothly. Normal scapulohumeral rhythm is defined as a 2-to-1 ratio of humeral to scapular motion. The first 60 degrees of humeral motion is typically independent of any scapular motion. The remaining 120 of humeral motion is typically accompanied by complementary scapular motions. If there is pain in between 80 and 120 degrees of motion and then disappears in the upper third of the movement, this is called a painful arc and can be caused by a supraspinatus impingement. Assess internal rotation by asking the patient to move their hand behind their back, and external rotation by having the elbows locked into the side of the body to prevent scapular movement and rotate the arm out to the side. Passive range of movement. Ideally, this should be performed with the patient laid down to aid relaxation of the patient and the muscles. However, pain may prevent this, so they can be assessed sitting. Flexion and abduction of the glenohumeral joint are performed, ideally stabilizing the scapula to ensure pure glenohumeral joint passive movement. Keep the elbow tucked into the side to perform passive external rotation. Passive internal rotation can be assessed with the arm in 60 degrees of abduction. External rotation can also be observed in this position. Supraspinatus is tested at 30 degrees of abduction while you resist abduction. The infraspinatus anterior minor is tested with the patient's elbow into the side while you resist external rotation. The subscapularis is tested with the elbow into the side while you resist internal rotation. This is also testing pectoralis major and latissimus dorsi, therefore this test is not very sensitive. If there is concern with regards to a subscapularis tear, you can do a lift-off test. This is where you take the hand behind the back and ask the patient to lift the hand off the back or bottom. They will be unable to do this with a subscapularis tear. The bicep is tested whilst you resist the patient's elbow flexion, or the patient's elbow is extended, forearm supinated and the humerus elevated to 60 degrees whilst you resist humeral forward flexion. This is called Speed's test. Here are a few further tests which you may find useful in your practice. To test for a rotator cuff tear or absence of function, you can do the drop arm test. Abduct the shoulder passively to 90 degrees. Ask the patient to slowly lower their arm. Pain and weakness can indicate a tear. The patient may hunch the shoulder and lower the arm using the deltoid. The sulcus sign is a test for multiaxial instability, but can also be positive with a rotator cuff tear. Apply a downward traction to the humerus by holding above the elbow. A positive test is when a sulcus appears between the acromion and the humeral head. You must compare it to the other side, but 2 cm of translation is considered positive. This can be palpated and is easily seen. To test for impingement, which indicates a disorder within the subacromial space, a very reliable, quick and easy test is the Neer's impingement test. You perform maximal passive abduction in the scapular plane with internal rotation whilst stabilising the scapula. A positive test is pain in the subacromial region. To test for acromioclavicular joint injury, use the scarf test. Ask the patient to move their arm up to 90 degrees and then into horizontal adduction. Compress at the end of this movement just above the elbow, and if there is pain in the end range, it is suggestive of a acromioclavicular joint injury.